we're going to go over the respiratory infection surveillance tools that are just being launched for long-term care. There's a number of tools, 4 in total, that we'll review. I will go over the line list, both for the clinical staff on the units and for the ICSAs and IPNC folks to use when they move into an outbreak. We will review the case definitions, which were recently launched from nationally through IPAC Canada. And then we'll move on and review our new database that Myrna has devised from the templates that were provided from IPAC Canada and their surveillance modules. Quite robust tools. I'm sure that all of you have seen some or maybe all of the tools in the past. There has been some minor tweaks here and there to have them function the way everybody is hoping over the next little while. So exciting times, and I'm sure there will be lots of questions as we go on, but we thought for now we would provide you with this brief education session that folks could watch and review in their leisure and refer back to it should they have individual questions. You are more than welcome to reach out to your WRHA IPNC contact at any time you have questions. One of the goals of surveillance is to do great data collection, having it clear and concise and appropriately applying case definitions so that the data you get is quite clean and very usable as you go forth and compare to others and make changes in your facility. So over the next little while, we are going to be very concentrated on folks learning data collection and applying those principles well to the tools that are provided so that we get some robust data in order to build change in the long-term care world. So the first tool that I have here is the clinical paper copy for the line list. So what you're looking at is a printed line list. It will print on two-sided, one side, and then the back side will have some information that the staff will find handy in order to complete the information in the line list. Each month, the ICSA at the facility or somebody on their behalf will provide a brand new printed copy of a two-sided legal line list. The nurses on the unit will look at the line list on a daily basis, every shift, and add any information as they go along in order to make sure that the residents, anybody with an infection has been added and their symptoms have been appropriately charted. When you're adding a person to the line list for the first time, the nurses will print out their name in the line, and then that nurse will put their signature at the end. As you go along, say tomorrow, they develop a cough that they never had when the initial entry was made. You can just add that information by just signing your initials. So for myself, if I notice they had a sore throat on day 2, I may add to Shauna's entry that she made the day prior by putting my initials DC in the sore throat column. So it's very clear to everybody who's looking that Shauna never added the sore throat. Davina added the sore throat. So if you had to ask me questions to gather further information of why I felt that resident had a sore throat, you would know who to direct those questions to. Okay, all of this is reproducible data. So in terms of record retention, what we're going to ask is that the ICSA gathers it up and keeps the hard copies so that folks can have that to refer back to, but it doesn't replace charting in the charts and making it a part of the permanent resident's medical record as you go along. So definitely want to have good, clean, concise, and accurate data in here, but you still have the responsibility to do the charting as you go through things. You'll notice a few things on the line list that will require a little bit more attention. They have little asterisks on them. If you turn to the second page on the paper fillable line list, you will see the constitutional criteria listed, and that tells you how to answer that. So for example, if I'm going to say somebody has a fever, they will have had to have met one of these 3 criteria to be able to be considered to have a fever. So it doesn't necessarily mean that their temperature has to be as high as 37.8. It could mean that they have repeated oral temperatures over a certain degree, or a single temperature that's above 1.1% above their, or 1.1 degrees Celsius over their baseline. So this is important information to factor into the way you complete the line list for each individual resident. Okay. Now this line list, I'm just going to switch my screen here and bring up the next document, which I will just bring over here. This line list complements the ICSA's tool for outbreak management. Okay, so you'll notice that this outbreak line list that I'm showing you right now looks very different than what you would have seen in the past. What it does is it mirrors your HAI surveillance. So anything the nurses are filling out on the units, this is going to mirror exactly that information. So when the ICSA goes through reporting their outbreaks, they don't have to figure out how to make information fit into their reporting template. It automatically aligns, which is a benefit both for the clinical staff and for the ICSA and for any ICP that's interpreting the results. You'll notice that there's additional columns that we've added to the outbreak line list that the frontline clinical staff will not see on their hard copy. This electronic information is located at the end, and it actually talks about whether or not you meet the criteria, like is it an HAI? It talks about reliable isolation, which all of you know that we've had many conversations about reliable isolation in PCH. So it allows you to make a yes/no comment there to help us evaluate as we go along in an outbreak. Talks about the date the lab confirmed result was available, so that's important when you start to get into managing your outbreak. Has a little spot for comments that anybody can add things, and then at the end, of course, there's an outbreak code that you can add. At the top here, you can add if oseltamivir prophylaxis was started, if you had an influenza outbreak, so that would be the date that you started giving the prophylaxis. And then you'll notice at the bottom, the line list here is, it can be repeated. So you don't have to have all of your outbreaks on one line list. You can copy and paste this and add additional pages, just like you do now. The only difference is this is going to look a little different than what you're used to putting your information into. Okay. Now, the only time you need to take the hard copy information and put it into this electronic line list is when you're dealing with an outbreak. All right. If you don't have an outbreak, the hard copy is more than adequate. Just keep it in your files, just like you would have with the old infection surveillance reports or ISRs that the staff used to fill out and send to you. You do not need to recopy that hard copy line list into this electronic format for any reason, unless you become in an outbreak, and then you're going to want to submit that data electronically. Okay, so those are the two line list or tools that were used to gather data. Any questions or anything that I missed from the ICPs that are on the call right now? Or anything that I've confused with that you guys want a little bit more detail on? Okay, so I must have remembered everything, which is awesome. So let's move on to the respiratory definition. So I'm hoping that this screen changed and you now see the respiratory definitions. Okay, so the respiratory definitions, there is an article that's been published with these definitions in it and many more. It would have UTI, wound and skin, and all of those other definitions that have been updated as well. For this particular project, what we're starting with is really respiratory surveillance and really becoming very clear on how that is done, and then we'll move into those other areas. So this is the ICSA's and any site-based ICPs that are supporting that work. This is their definition page for respiratory. So first things first, you're going to want to become familiar with these new definitions because they've changed since since the 2017 ones that we were using previously. And so a good read and including all of the red font, which is really about application of the definitions, is really required. The other thing is after you've read them, if you have specific questions about application, that's a great discussion to have with your WRHA IPNC rep, because they will help you walk through it. And the more you apply them, the easier it will get in terms of really learning how to apply them and what the and how they should function in real life. When you read the definitions and compare them to the national definitions, you will notice that we have added influenza-like illness. So the national definitions don't have this criteria. We've added it because we want to pull that information out and be very clear on the numbers of residents that are meeting the influenza-like illness case definitions. So in order to be clear on when you apply this or how you apply it, we've also added some application criteria in red underneath, and it basically says if the criteria for ILI and another upper or lower respiratory tract infection are met at the same time, only the diagnosis of ILI shall be recorded. And you'll notice a little bit of application information similar to that throughout these definitions. And it's really because some infections could meet multiple categories. So you really want to know where to put it, because you should only be counting each infection one time. Okay? As you move through all the different categories and work through your information and how you apply it, you're going to notice on the backside there's the constitutional criteria. So this is the same criteria that the nurses had on the backside of their line list when they were applying some of their information to that handwritten line list that was left on the units. You're also going to want to be aware of this so that you understand what they're using as a definition to apply that. And then last but not least is the HAI, so Healthcare Associated Infection Attribution to the long-term care home. So somebody could have an HAI, but it doesn't necessarily mean it's applied to your PCH. So you want to make sure that with every HAI that you've diagnosed and you see it meets the criteria for infection, that it actually had no evidence that it was incubating prior to admission. So if a resident was admitted to your home yesterday, developed symptoms of infection today, that is not necessarily your home's attribution, and it shouldn't count in your stats for infections. In those situations, it's always great to have a conversation with your WRHA rep and make sure that you're applying that criteria accurately, but certainly with every resident, you should be questioning whether or not that infection is a actual HAI infection that's attributable to your facility. Where it gets tricky sometimes is if that infection happened while maybe they were 2 days, 3 days, 4 days back from hospital, and so then you wonder about combined attributions and sometimes digging a little bit deeper about exposures, and so those are often big conversations that we have, and we loop Myrna in as well. So certainly willing to work through those as we go along. It's really hard to give examples because each situation is very different and often generates quite a bit of conversation. So right away, we're going to have Myrna go on to the database. But first, I want to flip back to these HAI surveillance lists. So I've brought up the one that you would use for outbreaks only because I have a little bit of data in here. So please just forget about this part and just consider the data I have in here and understand that what the ICSA is going to do after they pick up this paper copy from the units is they're going to take those case definitions and cross-reference them with all of the symptoms to see if that person meets the criteria for infection. Okay, and once you've determined that Mickey Mouse does have certain criteria to meet one of the infections on the definitions, perhaps COVID-19, because he does have the positive viral test by PCR in the past 14 days, then you know that you need to add him to the database, which Myrna will walk you through right away, as an HAI or healthcare associated infection. Okay. Any questions about the criteria that I might have missed? Okay, good news. All right. Myrna, you're going to share the database, or would you like me to share it for you?
I will share, if that's okay.
Perfect. That's perfect.
Okay. The database is constructed in such a way that the tabs at the bottom tell you something about what you're going to see in that page. The orange tabs or yellow tabs, I'm not sure what this color is exactly, has information in it that you need to read through before you actually start using the database. It has a glossary, and then it has instructions. And some of these instructions are very important to know before you start actually putting in data. because some of them say put in the unit names first, and then if the same resident develops more than one infection, use a new line for each infection. So those are important topics that you have to know before you actually start putting data in. So I encourage you to read all 3 tabs first and then move into, as it says, the Units tab next. Now my supposedly PCH here has 10 units, and they're all labeled West, but they're labeled West 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11. The minute you put your units in this spot, which must be completed first, they will show up in this spot over here, where you will then be able to put in your resident days for that unit for that month. And then all the other calculations will be done automatically. The light yellow coloring here is where you need to actually put your information in. First the units, then the resident days. And the calculations below for the quarterly data will be automatic. So that's important to do first. The next tab is where you start putting in all your respiratory infections, and that's what we're going to start with. And yes, you can see that we're going to move into others later, but we're going to start with respiratory and make sure we understand what we're doing and that it's running smoothly before we move into other types of infections. You should include your facility name, the year, and unfortunately there, that makes better sense now. The year that all my data is in is 2023. And then I've started adding data. In January, because you picked from a drop-down, and I picked January, Mickey Mouse, who was on West 2 in room 201, and the symptoms started January 1st, and it was an HAI, had COVID. He met the criteria that were in the definitions page for COVID. The next, on the same day, but on a different unit, West 3, Donald Duck had a healthcare-associated upper respiratory tract infection. And that's how you would flow through your data, adding it person by person. And if, let's say, Donald Duck is here on West 3 in January, but in February he has a different infection, he gets a new line. Even if this was January again, he would get a new line because every infection that's new gets a new line. So this would make sense then. So he got COVID again. So first he had an upper respiratory infection and now he has COVID. So he's very sick. But that's how you would respond to when you have a person that has 2 infections in the same month. They would just get 2 lines and you would put their X, a capital X, in the correct column that matches the respiratory infection that he meets the case definitions for. And you add your residents as they have infections. And this includes outbreak cases as well as non-outbreak cases. So sometimes you will have lots of cases on 1 month, and sometimes you will have less cases on 1 month. I didn't quite get all my data in here, but as long as you have this part completed, which you will do, then it will run the reports the way they're supposed to. By putting in this data, all the tabs that are white at the bottom will automatically calculate things for you into tables and into graphs. Since we're only putting in respiratory infections right now, we can see that we have an annual total of 34 infections, and they range in months based on how they were entered onto the first tab, the infections tab. And the resident days were also automatically calculated for the facility total, and then it created a rate beside that. So this first graph you see here is the number of infections that are hospital associated. Second graph here is the rate per 10,000 resident days that occurred each month for the whole facility. Now, if you're thinking, I want to know what one unit is doing versus another unit, the next tab, respiratory infections, must help you a lot more. It will break down all of your infections by month and by unit, and all of these units will automatically fill when you have completed the unit section in the units tab. So that's why that's done first, so that then everything, the drop downs in the infections area where you put data in, as well as all your tables, will put in the units that you will need. And so this is, we again have 34 infections over the entire year over the whole facility, but you can break them down now by unit and by month. And then below you have healthcare associated infections by unit and by month per 10,000 resident days. And first, the graph here shows you the number, just like in the other page, and then below it is the rate. Now, if you don't have 10 different units, and these are blank over here, I'm just going to go down to units and erase the last 3 just to make it complicated. These will end up with zeros in the data spot, so that you won't have any data there, you won't have any names, and it will just be zeros. And so in your graph, you'll have these 3 boxes that don't mean anything. You can click on the individual box and get rid of it so that your graph actually makes better sense for you. And then you can copy and paste this into your reports as you wish. And you can copy and paste the rates too, but I would just copy this area because these you don't want to include. Or if you can include those in your Word version, and then you can delete those 3 columns. I'm sure you'll be able to figure that out if you're comfortable with Word. After that, these are the tables that you're more comfortable with and probably used to for your reports previously. This is where you'd have all your infections by type and unit. Now we have less infections because this is just January to March. And they first tell you what type of infection it is and which unit it's on, and then it graphs the same thing. And below it does that in a rate per 10,000 resident days, and it graphs that as well. And since we're only doing the respiratory infections, for now you will only see bars in that section, in the RESP section. There are also tabs for April and to June, July to September, and October to December. And they do exactly the same thing. Just to make sure that the graphs work, I'm going back to put this in. And now the amount that you calculated in your total infections of 34 should match the total numbers that you get when you add up all of the cases per facility for January to March, April to June, July to September, and October to December. And so the formulas should work. We've been testing them over and over. And I think that's all I have to say. Does anyone have any questions?
I have one, Myrna.
Yes.
Only because I'm pretty famous for pressing buttons quickly and not realizing the impact. So I wanted to point out on the units page, you can't cut and paste on that page.
Yes.
You have it in red there, but I think everybody needs to really, like, the only person that should probably be using this database is the ICSA and perhaps like the DOC and maybe if they have an IPNC person identified at the site as well. So there won't be multiple fingers in the pie, but you can't, like if you've put your information in February and then realize it should have went into March, you cannot cut it out of February and put it in March because you'll destroy formulas and then your graphs won't work.
And your tables too.
And your
yes,
tables.
Everything breaks down. So if you are supposed to have 12,000 here or 1,200 instead of 1,000, you just have to actually type it in and change it. And then it will adjust as it should.
Right.
But you cannot cut and paste, otherwise that breaks all the formulas. That we've realized.
And then the other thing I wanted to add is when you're adding infections, the only infections you would be adding here is the ones that you've cross-referenced and they meet the case definitions. So if you have people that don't meet the case definitions, they're not going in this database. Yeah.
Correct. These are only the ones that actually meet the respiratory case definitions of COVID, upper respiratory tract infection other than ILI, the Manitoba Health definition, pneumonia, or the lower respiratory tract infection. One thing I also should have pointed out is that there is this one spot where you're supposed to tell us whether or not the infection was a healthcare associated infection for your facility. And it's a yes or no question. And although most of them will be yeses, there may be the occasion where a no comes along because let's say they came from a hospital in 2 days, they were already somewhat symptomatic, but they were only swabbed the second day, and they're positive and they meet the criteria. They are not a hospital-acquired infection for your facility, but they do meet the case definition. Putting this person into the line list here in the database will not impact your tables and will not impact your graphs. This person will be excluded if they have a no in this box.
And one of the things I would suggest in that situation, because it's always really clear when you're doing it and then you forget all the details, is I would actually move over to the comments section for Jane Doe and I would say attributed to St. Boniface Hospital or wherever they had come from that you've deemed that they're attributed to. Yeah. So then that gives you that little piece of information of why you didn't attribute it to that. And you'd be amazed how many times you have to go backwards and figure that out after if you don't leave yourself notes when you're trying to analyze data.
Yeah, exactly. Yeah.
Okay.
Any other comments or questions? Well, when you start using it, maybe you'll have more. Kathleen, did you have a question?
No, I'm good.
Okay. If anyone has questions when they were starting to use this and Jennifer, Kathleen, Shauna, or Davina can't not help you or they're not available at that moment, you can also reach out to me and I will help you walk it through. But case definitions and things like that, you should be walking through with Jennifer, Davina, Kathleen, or Shauna. I should not be your first contact for something like that.
Okay. Thanks, Myrna. And I think one of the things that will happen, because this will be released by the end of the week, I'm imagining. So, of course, timelines don't mean much here, but I would say, okay, so by February 1st, we should be releasing this. One of the things that will happen is you guys will set yourself up with the database as soon as you get it. So you'll put your units in, you'll name it for the year, and this will be your database for the year. So if we see improvements along the way, we are going to collect those up, and then close to January of next year, we're going to hopefully make a bigger and better database for next year. But this will be your database for the year as you go forward. So setting yourself up for success quite early on is great, and we can help you with that. So I know all of us will connect with our ICSAs. We will also help with the data collection. Once you start getting the line lists back, you can fax them to us. We'll apply the case definitions together and really make sure that everything along the way, each step is very robust so that all of you guys feel really confident and proud of the data that you guys are collecting and producing. And then we move on to reports. So that's sort of phase 2, which hopefully in the near future will give more information to the sites about. So unless anybody else has any questions, I think we're good here. And we will close the education session. Perfect. All right.